Good morning to some, good afternoon to most, and good evening to others. Welcome to today's webinar on making our commitments real to end the HIV epidemic by 2030, where we will engage in a faith-forward conversation following the UN high-level meeting on HIV and AIDS. My name is Ulysses Burley, founder of You Be the Cure LLC, and I'm honored to serve as moderator for this important conversation. Today's webinar is part of a series developed by the U.S. HIV and AIDS Faith Coalition. The series explores the 40-year legacy of U.S. faith communities toward ending the HIV and AIDS epidemic. It features conversations with a variety of leaders from faith-based organizations, houses of worship, community organizations, and government agencies who address the intersections of race, class, gender, sex, sexuality, and religion in the history of the HIV response in the U.S. and around the world. The event centers the commentary of faith actors from multiple faith traditions and practices, people living with HIV, and HIV practitioners who have been involved in HIV and AIDS advocacy since the beginning of the epidemic, and can identify lessons learned, offer insights, and share their vision for what will be needed to end the epidemic as a public health crisis. Last week, a high-level meeting on HIV and AIDS was convened by the United Nations to undertake a comprehensive review of the progress on the commitments made in the 2016 political declaration towards ending the AIDS epidemic by 2030, and how the response in its social, economic, and political dimensions continues to contribute to progress on the 2030 Agenda for Sustainable Development and a Global Health Goal. The high-level meeting provided recommendations to guide and monitor the HIV and AIDS response beyond 2021, including new concrete commitments to accelerate action to end the AIDS epidemic by 2030, as well as to promote the renewed commitment and engagement of leaders, countries, communities, and partners to accelerate and implement a comprehensive, universal, and integrated response to HIV and AIDS. Those leaders and communities include faith leaders and faith communities, some of which we have gathered here for a timely discussion. I'm pleased to introduce our guest today who will lead us in a faith-forward conversation following the United Nations high-level meeting on HIV. Reverend Canon Gideon Bayumugisha is an Anglican priest from Uganda. He was the first African religious leader to be open about living with HIV. Canon Gideon is the founder of Interrela Plus, the international network of religious leaders living with or personally affected by HIV and AIDS. He served as the faith representative for the civil society contributions to this year's United Nations high-level meeting on ending HIV and AIDS. Dr. Laurel Sprague is Chief of Community Engagement at UNAIDS, focused on centering the leadership of people living with HIV, men who have sex with men, people who use drugs, sex workers, and transgender people in the HIV response. Previously, she served as Executive Director for the Global Network of People Living with HIV, or GNP+, and worked for the HIV Justice Network, the Cero Project, and the GNP+ North America as part of the People Living with HIV-led movements to end HIV-related stigma, discrimination, and criminalization. Dr. David Barstow is a computer scientist by primary training, but for the last 15 years has been an AIDS activist with a focus on the role of faith communities in addressing HIV stigma and discrimination. He recently led an interfaith team to develop a set of strategic recommendations about the faith response to HIV in the coming decade. He's also a member of the core group for the PEPFAR UNAIDS Faith Initiative. After what I'm certain will be a robust conversation between Canon Gideon and Dr. Sprague and Barstow, we will have responses from Father Richard Bauer and Khadija Abdullah to offer reflections on what they heard from the discussion in the context of their own experiences as faith leaders addressing HIV and AIDS. Khadija Abdullah is a public health professional, entrepreneur, activist, and seeker of doing good. She is the founder of both the federally recognized National Faith HIV and AIDS Awareness Day and Reaching All HIV Positive Muslims in America, or RAHMA, a nonprofit that addresses HIV, female genital mutilation and cutting, sexual health, and gender-based violence in faith communities through advocacy, education, and empowerment. Most recently, Khadija joined the COVID-19 Prevention Network as a faith ambassador to engage faith communities of color in conversations around the efforts of COVID-19, disparities, prevention efforts, and effective community response. Dr. Richard Bauer is a Roman Catholic priest with the Mary Knoll Fathers and Brothers and has been involved in care and support for people affected by HIV since 1982. Since 1997, he has served in Catholic care and treatment programs for people with HIV, first in Tanzania, then later in Namibia, and now in Kenya. As a priest, board certified chaplain, and clinical social worker, Father Bauer has a wide range of experience with treatment, care, and support activities, integrating holistic, comprehensive spiritual and psychosocial care into clinical service delivery. Father Rick is currently the Director of Spiritual and Psychosocial Support with the Eastern Deanery AIDS Relief Program in Nairobi, serving over 400 staff members and 30,000 clients. What a dynamic lineup. Let me thank all of our speakers in advance for what I know will be a valuable conversation. At this time, I invite our conversation partners to share more about how faith communities make our commitments to end the HIV epidemic by 2030. They will be followed by our two responders, and then we'll open the floor up for written questions and comments from our viewers on all platforms. Dr. Barstow, Dr. Sprague, and Canon Gideon, the floor is yours.
Thank you, Ulysses. It's really an honor to be part of this conversation. Laurel, why don't we start with you? This is the beginning of the next 5-year cycle. The global AIDS response tends to be measured in these 5-year cycles. So where are we and where do you think we'll be in 5 years?
Thank you, Dave. That's a big question, but a really good one to start us off. And I just want to say also how pleased and honored I am to be here in this conversation with you and Reverend Canon Gideon, with Khadija and Father Rick. So it's really, really a pleasure. Where are we? Well, in short, we are, as you said, we're kicking off a new 5-year cycle. We've had high-level political meetings and political declarations every 5 years on ending AIDS. Just to set the stage, the last political declaration was in 2016 and set a number of ambitious but reachable targets that the world missed. And these were set for 2021. So we're in a place where we have seen remarkable progress and some countries meeting and even exceeding the targets in different regions of the world. It's not predominantly wealthy countries even. And yet we have a long way to go to end the AIDS epidemic. And so it was really an important moment to have a new high-level meeting and pull the attention of the world to HIV and AIDS, and also to come up with new political commitments by world leaders. I just wanted to note that the high-level meeting and the political declaration followed on a process led by UNAIDS to develop a new global AIDS strategy, which was adopted by our board in March of this year. And faith leaders and faith communities really played an influential role and a tireless role, I think, engaging in consultations and providing advice and support to the development of the global AIDS strategy. And then again, we're instrumental in mobilizing support and helping to draft or to recommend good language for the political declaration that was just adopted. I just wanted to highlight quickly, I hope I'm not taking too much time, but I just wanted to highlight quickly that in the political declaration, there are a number of strong commitments in areas that faith leaders and faith communities have really been pushing for decades, actually. And these are things that sometimes have been commitments previously in 2016 and before. Some of them are new commitments. But just to quickly run through a short list, and then I'll be interested to hear reactions and responses. We have real commitments on ending pediatric AIDS and on ending vertical transmission, which is transmission of HIV from women who are pregnant to their children. And also, even in that language, we now have language that says we want to end vertical transmission, which is much less stigmatizing, much more welcoming for women living with HIV who are pregnant than to talk about mother-to-child transmission. So that's a win for women, for families, and also against stigmatizing language. In that vein, we have strong commitments to end stigma and discrimination, including in the next 5 years to reduce stigma and discrimination, reports of experienced stigma and discrimination to less than 10% of people living with HIV. With our targets and language against gender-based violence, which churches and mosques and religious faith communities have really worked to push our attention toward and to address within countries for a very long time. Really strong prevention, testing, and treatment targets, which again, many faith communities have led the way in pushing for those and in actually providing prevention, treatment, testing, and care services. And then just the last thing that I'll note, although I could probably go on, is that we have strong targets on community-led responses. So really scaling up and supporting the work that's led by and for communities themselves, as we have more and more evidence that that's really how we reach people, that's really those people that are left behind, that have been left out or excluded or marginalized, are best reached by people who come from those communities. And we need to fund communities to reach out. So we need to fund people living with HIV. We need to fund Interrela Plus and religious leaders living with HIV. We need to fund LGBT people and sex workers, transgender people, people who use drugs, et cetera, really support and fund them so that they can do the kind of outreach that's needed to make sure that everyone who is living with HIV or potentially at risk of HIV has all the care, information, support in the world, everything that they need and deserve. And so what I'd like to do actually, because I had the privilege of convening with GMP Plus and AIDS funds in the Netherlands, a multi-stakeholder task force that Ulysses referred to in the beginning. It was a task force that was called for by the President of the General Assembly that had representatives of all different affected stakeholder, civil society stakeholder groups. And Reverend Canon Gideon served on that MSTF, that multi-stakeholder group, on behalf of faith and religious communities. And I thought it would be really interesting, Reverend Canon Gideon, if you would share some of your observations on the high-level meeting and the political declaration from your position and perspective, having served so well on the task force.
Oh, thank you, Laura. First of all, it was a really great privilege to be invited to participate in the multi-level task force on planning and being involved in the high-level meeting by civil society. So I'm grateful because it was a learning time, but also a time to contribute. And so the three perspectives I have, one was I saw a lot of commitment because in 2001, I remember 2001 when we were having a UN special summit, it was around whether states and state leaders are going to do a mere contribution or whether they are going to show real commitment. And it was really gratifying to see the office of the President of the General Assembly and his colleagues and UNAIDS and all of us in the multi-sectoral task force engaged in a committed way. That even when people were disagreeing or bringing different views, it was out of total commitment. It was, so that was gratifying to note that whatever problems or challenges we face, we are not facing them because people are not committed. Maybe because we are seeing them, maybe because there are different strategies or different suggestions of how people see the problem. So that, and that would be very good as a starting point for dialogue as we continue to now to implement the declaration that was adopted, that people are not just stubborn or they are not doing it because they are malicious. No, it's because they have a view that they strongly feel if we took the route would give us better progress. So it gives us good ground for dialogue. The second point I loved was the merging or the blending of the global AIDS strategy that had been adopted by the UN sponsor, by the UNAIDS sponsors and the board earlier, and seeing how that really was used as a resource into the high-level meeting. And for me, as a religious leader and as a person who was representing faith, it was a joy to see that the theme that is very poignant in the faith circles, that is of ending inequality, was the theme that really captured the attention of the religious leaders. It is gratifying to see language that is really religious being brought into the political sphere, because issues of inequality, issues of injustice, issues of helping the least of these and making sure that they come to the table, the language of making sure no one is left behind, that's a religious language. That is what we have been engaged with in our theology, in our ethics, in our spirituality, saying actually the ticket to heaven will be based not according to how much you believe, but how much you have practiced what you believe in helping the disadvantaged to come to the table of sustainable security and health, and of peace and justice. The last point I wanted to make was to see how the partnership between faith and the key populations, or the most at-risk persons, and the statesmen and women is coming up. I noticed that in how the sessions on plenary and the breakouts and the panel discussions were arranged to see that seamless collaboration and the partnership of blending the views to listen to one another. I think that was a very good for me to learn, to say, yes, if we take this spirit at the higher level meeting into our national level dialogue sessions and planning sessions, we will not only defeat AIDS, but we will defeat it faster.
Thank you both. Thank you both. I appreciate the Ken and Gideon, especially the way you brought in the partnerships. And I think we know the sorts of things that we need to do. To me, the challenge is how do we scale up to make it a broad enough use of what we know how to do. And as an example of that, and this is part of a 5-year strategizing, is say, well, where do we want to be in 5 years? And so I'm going to offer one suggestion about where we want to be. And that's that among local faith communities in high burden regions, there is widespread use of best practices. I think, we know kind of what the best practices are. Ken and Gideon, you've been preaching them for 20 or 30 years. The Channels of Hope teaches those. So I think we know what the best practices are. The question is, how do we make sure they're widespread? How do we build the capacity? I don't know how widespread it is right now. I think that would be an interesting question to ask. But we surely want to aim for a point where local best practices are widespread use of local faith communities. And Laurel, you're the head of the community element of UNAIDS. So there's got to be an interplay there between what local faith communities do and the way you talk about community action. How do you see that interaction playing out?
No, thank you. I love this. I love this attention to really thinking about best practices and scaling them up. I just wanted to mention that, and this language that Reverend Ken and Gideon brought forward about injustice. That thinking of inequalities really in a faith frame, that it builds on a long tradition of faith work. I really hadn't thought of it that way, and I feel really just enlightened by that comment. In terms of the community-led responses, I think it's really interesting to think about how that interacts with faith communities, because we're using the same word, community, right? And when we've looked at what works in terms of community-led responses, it is about communities doing work for themselves. The leaders of the community or community members themselves, organize and meet, organize to meet, advocate, provide services, document the needs of that community. And so I think in one way, faith communities have been doing that for a long time for themselves, right? So I think community-led responses by faith communities are partially what faith communities do for themselves, for their own members in those communities. And that community-led responses also intersect with faith communities, and that faith communities do a tremendous amount of work in the HIV response in many, many places. And the more that they can elevate the voices of people living with HIV, the voices of key populations, those who are most affected by HIV, and really ensure that those faith responses are centering and led by, it can be people living with HIV from their own faith communities, or if they're doing work in the larger community, making sure that that it's not just work done to other people, but it's actually a real partnership that really takes the lead of those people who are who are most affected, because they're the ones who we know just what's needed. And certainly it's really interesting with children living with HIV, who we know aren't going to be setting up organizations and funded and managing funds, and they're always supported by others. But I think the faith communities have come up with some really powerful ways to still provide space and leadership, as much leadership as possible, space for young people, for children to have some say in what's happening, to be able to engage with respect, to not just have things done to them, but to be brought in as real actors who matter, whose opinions matter. I think that there's some really nice ways to support children to do that. And certainly for those who aren't children, who are absolutely able to speak on their own behalf, there are ways to really support and welcome those voices and take them forward as part of community leadership. So I think that's really key, and look forward to seeing maybe some new partnerships and innovations that would allow that to come forward more and more.
So it sounds like among the best practices we want for local faith communities are, what are the best ways to engage with marginalized populations? Is that?
Yep. I would say absolutely. I think there's something else that I'd like to just add, if I could. At first, these marginalized populations are often part of faith communities already. Maybe not publicly though. Maybe they felt that they had to be in secret. So it may also be about supporting the faith community itself to be able to develop in ways that people can be fully welcomed as they are, embraced and supported who they are. So if they're LGBT members of the faith community, haven't been able to share that, there are lots of best practices, and there are many people working here that are even part of this call that know a lot about how to make welcoming spaces for LGBT people in faith communities, but also for people in sex work, people who use drugs, transgender people. They are in all faith communities. People living with HIV are all in faith communities. So it's not always having to go out of your own doors to be able to provide support. But I think there's also another group that I've been inspired to think about because of some of the work with the UNAIDS PEPFAR Faith Initiative and some of the leaders that are part of that work, that there's a whole group of people who are unreached, and they don't necessarily have HIV, and they don't necessarily know that they might be at risk for HIV, but they may hold really discriminatory or stigmatizing attitudes toward people who do have HIV or who come from different marginalized groups. And I think that faith communities can really have an opportunity to reach those people who've been unreached by messages of anti-discrimination, anti-stigma, or unreached by the messages of the medical advances that mean that people living with HIV can live full lives, can have healthy babies, can have relationships where no HIV transmission occurs. So I think there's a lot that's moved forward in the HIV field that's not known outside the HIV field. And within faith communities, there are a lot of people who haven't heard this new information, much of it very good news. And there's a real opportunity to address stigma and discrimination by community-led work within faith communities to make sure that information is shared and people are really brought on board, especially into processes to end stigma and discrimination.
Yeah, so that says another set of best practices had to do with the fact that faith communities meet so often. It's a way that you can share information on a regular basis and continually repeating messages about respect and dignity for all, and so on. Yeah, Reverend Gideon, Canon Gideon, you have been involved in interfaith activities for a long time. What can you say about the best practices for working in an interfaith way on some of these issues?
Thank you very much. When we started the international network of religious leaders living with or personally affected by HIV in 2002 in Zimbabwe, we deliberately, by then actually it was not international, it was Africa network. We were faced with a situation of whether we should talk about Christian leaders living with HIV or personally affected, or whether we should talk about religious leaders, meaning we bring on everyone from different faith traditions and persuasions. We took the tougher option of bringing in everyone because we realized that stigma is stigma, irrespective of whether you are a sheikh or a Hindu priest or an imam or a priest like Gideon. And so we've been learning lessons along the way. It's not very easy, but what on earth is easy? But we have learned, like, for example, as we move along, the first guideline is establish ground rules. What things bring you together, and you focus on that and leave out those that you are not in agreement with. For example, if the focus is on AIDS, let that be the central focus of why you are together. So when, for example, I got questions of why do you have key populations in your network, it was very easy to answer because we said our point is to bring together people who are either living with or most at risk of or personally affected, irrespective of who they are and where they come from. So it is very important to establish a point of engagement. The second one is to blame each other less, listen to each other and empathize with each other deeper so that you are able to support and accompany and engage each other better. That's very, very crucial because you realize that you are in this battle together. When AIDS strikes, it doesn't leave out any religious persuasion. It strikes you quickly. I mean, equally together, like the way famine strikes or environmental disasters. So the other one is to make sure that we develop evaluation mechanisms of what is working well and what's not working well. So we usually, when we meet, for example, for our dialogue sessions or training sessions, we have 4 questions we ask each participant. What did you like most? What didn't you like? Is there anything new you have learned through this dialogue or this meeting or this training? And if it is, if it is there, what is it? And finally, do you have any other suggestions? And it is through such self-audit things that you discover things to improve. For example, when we held the post-Bangkok Interfaith AIDS Conference, there was a lot of variety. The Buddhists were there from Thailand, the traditional voodoo priests were there, and everyone was there. And so we had in the 4 days to make sure we put ground rules of making sure that everyone is involved. And when we asked them the question, what didn't you like? The Christians wrote and said, we didn't like just hearing Jesus 4 times only. But that would mean that now the issue of bringing in other voices to speak and to be recognized on the table was being felt so that people are all comfortable to belong and they are all engaged and they are all participating. Now we are running interfaith services to end AIDS faster before 2030. We are holding them every month. And again, the same tactic of making sure that you have a theme, a common theme that energizes you. For example, for us, we have said we want to defeat AIDS 5 years earlier than the 2030 target. And that one is making everyone really on their toes to make sure that we get the award of being the first interfaith network to defeat AIDS earlier than the global and the national target.
The targets that are in the UNAIDS strategy actually are pretty ambitious. So you're going to have to work pretty hard, Ken and Gideon, get there. But you know, one of the things I like about the UNAIDS strategy is it includes measures of progress and targets and things that we're aiming for, even in a quantitative way. And I think that's an approach that we could benefit from in faith communities. I know we're running out of time for this conversation, so it might be worth taking a look at a different piece, and that's, you know, we've been talking about where we want to be in 5 years. It'll take some commitments, a number of commitments by a number of different of faith institutions and religious leaders to get there. And that was actually one of the nice things that came out of the interfaith conference that was held 9 months ago. There's a list of 15 commitments that we are inviting people to take, commitments for the actions that they're going to take over the next several years. So to me, that's an important place for us to put some emphasis. Laurel or Ken and Gideon, any thoughts on that?
Moving forward, yes, every commitment we have adopted for ourselves, either from the fall statement or from the face to end AIDS and inequality that has just ended, or the societal enablers that have been mentioned in the political declaration document. I love that one about the societal enablers, the 10 by 10 by 10, you know. Yeah. That one is very powerful. We can do, if we adopt the right framework. For us in Inerera, I think that was the best gift we gave the faith movement, that we need to have a framework that uses a language of community. We only had a language that was targeting individuals at risk: abstain, be faithful, use condoms, to the individual at risk. We didn't have a language that could involve community mobilization and target leaders to be involved and put stigma and discrimination at the center. But when we evolved that and many faith communities began using it, that is multiplying safe behaviors and practices, increasing access and adherence to treatment and nutrition and good care, voluntary routine and stigma counseling and testing, the empowerment of the most vulnerable, and then eliminating stigma and discrimination. Once those 5 variables are put together and each faith is allowed to tackle each of the elements from the point of the best strength, and then they are given support in measuring the 11 variables in each of those, the passion, the levels of passion, the policies, the plans, the programs, the partnerships, the messaging and the communication, that is the proclamation, the prayers, the praise points, but also the research, and finally the money, the PURSE, we call them PURSE, PURSE. Those points that people can measure and say, we are doing well, we are doing average, and we need to improve. We will do what we can, and then God will do what we can't.
I'm so excited by that, by all of that. I'm just thinking, just to add something further, the commitments are ambitious and they are reachable. And I think that we can talk about how we jointly think about our partnerships to be able to reach those commitments, because we can't reach any of those commitments without some political will and political leadership. And so there's the work to build community and solidarity that Reverend Canon Gideon is speaking of, which is going to be essential for the political will to exist, to be able to reach the commitments and AIDS. There's the community mobilization piece that's important. And then there's also just the very special place that faith leaders hold within countries, especially with political leaders, that there are places and conversations that faith leaders can have that others can't have. And there's language that can be used around perhaps injustice, this language that we're hearing that have so much credibility when they come from faith leaders, and maybe won't be listened to with the same the same attention, let's say, when they come from other, especially people who are most affected or living with HIV, who are not faith leaders. So I think I'd love to see some work on best practices in advocacy by faith leaders, and really seeing how faith leaders have been able to use that position in ways, we know sometimes it's used in ways to lead to discrimination. We've all seen that on the world stage. Really nice to also see what I think is often quieter work, how faith leaders have been able to effectively use advocacy for good policies that save people's lives. So that's something I would really, I'd love to see in place long before 5 years, so we could see some results from that by 2025.
The commitments in the political declaration and the UNAIDS strategy really are ambitious, and those 10-10-10 that we talk about the social drivers, we're never going to get there without a lot of faith involvement. That's I just don't see how it could happen otherwise. But the good thing is we've got faith engagement, and so we just need to scale it up. It's not a question of, again, of figuring out what to do. It's just doing more and more of what we know works. So Laurel, I appreciate what you said about advocacy and the importance of religious leaders in that, and they bring a moral dimension, a dimension. So this is a moral imperative to end AIDS.
Yeah.
It's and that to me is sort of the strength that all faith communities bring, and that happens at the national level and it happens at the local levels. That's one of the reasons why we need to have such widespread use of best practices by local faith communities, because they influence the attitudes not just of their members, but also of the wider community. So if there is a sufficient amount of this of messaging within the faith communities, it spreads to the whole community, and that's the leverage point, that we have that seems like it'll be critical to take advantage of if we're going to hit those 10-10-10 targets.
Yep. And we can, because the faith sector has two mission statements: the in-reach and the outreach. And the in-reach is really, practical action on the ground in the faith communities and the congregations, whereas the outreach is the advocacy arm. And once we do both of them well, we will do our part.
I think that's a wonderful segue to hear from our responders who are local faith leaders, who are exercising best practices, who are doing in-reach and outreach, as Canon Gideon so eloquently stated. I've been so grateful for this robust conversation that has happened over these last 30 minutes. Dr. Barstow, Dr. Sprague, Canon Gideon. I'd like to now invite Khadija Abdullah and Father Rick Bauer to join in the conversation to share a bit with us about what they heard and how what they heard interrelates in their own personal work as local faith leaders, what best practices have worked for them in their respective roles, and the ways in which they envision us reaching these targets as a faith community by 2025 and ultimately 2030. And so I want to first invite Khadija Abdullah to tell us what she heard and how she's thinking, and then followed by Father Rick Bauer.
Thank you, Ulysses, and thank you everyone for such a great conversation. I was listening and nodding my head a lot off camera. I come from a faith background. I kind of started this work due to faith and seeing the stigma in faith communities around HIV and AIDS. For those who don't know my background, I met a Muslim man living with AIDS when I was in college, and he told me he didn't feel safe in his faith community because of the stigma and the miseducation and misconceptions around HIV and AIDS. And it really bothered me, and it maybe had to address my own stigma because I realized I didn't know much about it either. So it kind of pushed me to start Rahma, which means mercy in Arabic, and try to find a way to address stigma in the Muslim community at first, to create safe spaces and whatnot. But as I've worked over the years, we see that stigma is in all faith communities. So seeing this topic being discussed and seeing the push from faith communities and how you see a lot of religious texts, as Reverend Ken Gideon said, in the declaration and whatnot, it's really heartwarming to see. And hopefully before 2025, we make a leeway, like Laurel said, Dr. Laurel, before 5 years, make a leeway in, addressing this. So I agree with many things that were mentioned. I agree that community-led response is very, very important. You cannot do it without the community. The community is where it's at. People trust their community. They trust their leaders. They know their community. So if you have someone coming in from the outside trying to, it could possibly work, but I think you definitely, as we've seen over and over again, that is much more important to utilize the community itself to have a better response. So I think continuing to do that is very, very, very important. Engaging in vulnerable and marginalized populations is very important as well. So, one of the things that we've done, and a lot of people on this call are part of this as well, is we've seen that working together works. So we work together for Faith Awareness Day, and we have at least 7 or 8 faiths that come together every year, and more people who are spiritual as well. They come together and try to address HIV stigma because people do not feel safe in their faith communities. And some of the things we're trying to do now to continue the work, we just got a grant. We're so excited about this. We're doing a program. This is part of it. Reverend Schudemeyer, Dr. Barstow. We're working on trying to put together a video amplifying faith, the voices of faith in our faith communities and HIV and AIDS, and showing that, people have left their faith communities because they don't feel safe, they don't feel welcome, whether it's LGBT people, transgender, whether it's, Black women, Black men, minorities, all sex workers, drug users. If they don't feel safe or they feel judged in their faith community, like Dr. Sprague said, like they might be in the shadows. And we don't want that. We want people to be able to identify their faith or spirituality without fear of repercussion. So we're doing this video series and educational program, and where we hope that we can really, really reach even further and further this, declaration as well and reaching faith communities. So you'll see more about that. We'll probably announce it around Southern AIDS Awareness Day and Faith HIV AIDS Awareness Day, both in August. So stay tuned. But we have a lot of things we're doing to try to advance faith communities in addressing HIV stigma. And then another thing that we saw to me from Reverend Ken and Gideon is where he said we got to stop blaming. Yes, like that gets us nowhere, and we're blaming each other. We need to support each other because this is the only way we can move forward is together. And Dr. Laurel talked about pediatric AIDS and ending pediatric AIDS. I've had many friends who are positive due to vertical transmission, and I've lost friends, unfortunately, through complications from advanced HIV or AIDS. And there's stigma around. To this day, there's still stigma, even here in the US. I know talk about different countries, but even here in the US as well, there's stigma around mothers, who have children who are born positive. And I think that we use less stigmatizing language, provide more support, and we end stigma and discrimination. It can be helpful to everyone. So I'm really, really hopeful about that. And more recently, Rahma has started working more on gender-based violence. So, we created a toolkit recently that's focused on FGM, our female genital mutilation prevention. And a lot of women and girls go through so much violence when it comes to FGM. They're cut as babies. They have no say over the rights of their bodies, or what happens to them. Or some of them happened to them as young girls. So they remember their experiences. And we are doing this thing now. We're pulling in faith leaders. We're adding a part to our toolkit that's focused on faith actors to really, really come in, because a lot of people feel like it's rooted in faith, you know, and they use faith as its justification. So it kind of ties in with the recent political declaration about expressing concern on GBV with women and HIV. It's still the same as violence against women, and something we have to address. And, you know, we have to call out men, because men have a voice too, and they can help in this violence. And a lot of times it's at the hands of men that women face violence. So we really need to talk about this, and we need to pledge together to reduce HIV infections. And there's also a correlation to HIV and FGM, but I don't want to go too deep into that today. But I think that I'm really excited about this. I want to get more involved with this. And I think we really could do these measures. They are a little ambitious, but I think that we could do it if we all work together to really make this happen. You know, we've done this work for a long time, not me specifically, but a lot of people in this space for decades, for 40 years now. And, you know, we've come a long way, but we still have so much further to go. You know, we have so many people, different faiths that need support, and they need direction. Like, people want to help, but they might not understand. They can't use certain words. They can't say certain things, or they might have outdated information about HIV or AIDS. So by us coming together and providing this information and providing support, we can really come together collectively and end it by 2025.
Thank you for that, Khadijah. Father Rick, what did you hear? Tell us about the work that you're doing in your context.
Well, yeah, I'll just jump right in and in 5 minutes or less solve the HIV dilemma and bring about world peace. You know, I know right now, you know, this is the proverbial preaching to the choir, but I think I need to say it out loud that we as faith leaders need to be strong as AIDS advocates. AIDS is not over. And I was just in New York City for another aspect of my life, and someone asked me what I do, and their response was, I thought we cured that. So we need renewed, as Khadijah just said, videos. We have got to get this out there that AIDS is not over. I agree with Canon, you know, Gideon, we need that renewed commitment from the faith communities. I'm one of those old timers. I go back, you know, when I was at St. Francis in San Francisco, we were talking to St. Vincent's and St. Clair's in New York City and St. Vincent's in Sydney, you know, what's going on with this new disease that we had no idea what was happening. And faith was there in the beginning. We've been there all along, but we need that, definitely need that renewed commitment. So much of what I hear in the declaration, in the global AIDS strategy, is a biomedical solution. Gratefully, we're hearing more about the importance of human rights and human dignity in the HIV response, but I really believe faith communities need that. Unless we have a bio, psycho, social, spiritual response highlighting every domain of the human person, we're not going to end this. And that means how we treat people living with the virus, how we welcome them, and how we train healthcare workers, all cadres of healthcare workers. I think COVID and certainly HIV have taught me that we need to move from healthcare systems to caring systems of health, that the caring is at the very beginning. A recent study in the US said that a patient has 11 seconds before their physician interrupts them in a clinical interview. That is not listening to the patients. That's not, as Laurel said, engaging people living with HIV who have, and helping them develop our programs, our interventions, and how we bring this about. I've come to understand that what we do in terms of healthcare interventions can be just as important as how we do this. How do we welcome people? How do we as healthcare professionals end that discrimination by looking at dignity and respect and listening? As we search, and UNAIDS and PEPFAR talk about finding those lost, those last remaining positives, because it's really changed. Even 5 years ago, we could do big, huge community testings and test 20, 30,000 people and find positives and get them into treatment. One, we just don't have the funding for that. Our testing is more targeted, but we have to do that in a way that doesn't stigmatize people, and using people living with AIDS and their peers and faith leaders who know who may be most at risk in new ways. We absolutely, as the strategy and the declaration say, we need the best and we need the latest biomedical medicines. Absolutely, I agree 100%. We need safe and effective medicines and diagnostics, but we also need the same supportive care, mental health treatment, substance abuse treatment, all of those, and as Laurel said, community-based support and care if we're going to end this. A lot about what I read in the documents is, and what we talked about so far, is what we're going to do. I think as people of faith, we need to emphasize why we're doing this. And this gets around to how I understand, community. Community, that English word that comes from common unity. It's really easy to figure out how we disagree in theology or ethics or morality, but we're going to end HIV when we look at our common unity. And I think some of that gets us to the why we're doing these things. And it's what Gideon, also mentioned. It's our ethical tradition, both within religious communities and with people that don't have an explicit faith or religion, how we emphasize human dignity, the common good, the right of every person for health and life and human decency. I personally believe that communities of faith should be where government cannot or will not be. And that's where we need to go, to the margins of society. And so, as has been mentioned so well today, with key populations, our transgender brothers and sisters, LGBT plus brothers and sisters, we can also need to be the voice, as Romero said, of the voiceless. That's migrants, that's refugees, that's internally displaced people who nobody wants right now, and globally, in desperate need. I also fear that, because it's a lot of my friends and colleagues, that we're forgetting some of the elderly that are newly infected with HIV, and elderly that are long-term survivors, that we have no idea what HIV is. This HIV is this aging from a medical point of view. And so we can't forget that. And I think, I forget who said it, I have been very involved with the Vatican Commission on Pediatric Formulas and Pediatric Diagnostics. Still globally, 53% of children with HIV are on treatment, compared to almost 70% of adults. Neither one of those figures is acceptable, but the 53% of children globally that are HIV positive on treatment is just completely unacceptable and is a real call to action. And I know my time is running out, so finally, I haven't heard this yet, and this is a critique of myself personally, as well as a challenge to all of us. In the early years, I was spending a lot of time educating bishops' conferences and priests and clergies, about AIDS and HIV. And especially when treatment came along, we went totally biomedical and we left them out of the conversation. And so I'm really glad that PEPFAR, through the Faith and Community Initiative and the Messages of Hope, we're going back into faith communities to teach those pastors the basics, about where we're at right now in the pandemic, and how, they don't have to preach AIDS kills anymore, but that there's great treatment, and lifelong treatment. And so we've really got to bring them along in education and commitment. And finally, our ethics of solidarity. We all, most of us, I think, agree on that social ethical teaching of solidarity. And that means there is no more us and them. There is only an us. And I think that's how we fight the stigma and discrimination, both within our healthcare systems and within our faith communities. We also believe in peace, and yet we know, and certainly from my own tradition, there is no peace without justice. And justice means the availability and the accessibility of treatment, of diagnostics for HIV for anyone on the planet, anywhere that is infected. And that we bring this into, again, a bio, psycho, social, spiritual model of healthcare.
Amazing. I really resonated with much of what you said, and I look forward to delving a little deeper in all of your points during the discussion and question and answer period, which we will transition into now. And so I would invite all of our participants to cut their cameras on, and I would invite the audience, those of you who have tuned in via Zoom and those of you who are watching via various social media platforms, to please enter your questions in the chat or in the question and answer box or in the comment section on the social media platforms so that we can have these very capable experts be able to address your questions over the next 20 minutes or so. But I'll get us started. One of the common themes I heard throughout the conversation, especially in your last comments, Father Rick, were about money, right, and investment. Canon Gideon called it the purse, P-U-R-S-E, about the importance of the purse. And not just the funding for HIV, but specifically the funding for HIV in terms of biomedical innovation. And here in the United States, HIV is the largest funded endeavor by the National Institutes of Health, but it's almost 100% biomedical, right? And if COVID-19 taught us anything, it's that we can't end a medical pandemic or medical disease with biomedicine alone. There has to be a significant investment in communities. And I heard all of you say that. And so I know, one of the things to emerge from the UN high-level meeting was a recommitment of member states to invest almost $30 billion annually through 2025 toward ending the HIV and AIDS pandemic. But of that 30 billion, only about 10%, 3 billion is allocated to really addressing the inequalities that we talk about that drive disease, those social determinants of health, right? Poverty and gender-based violence and discrimination and stigma. And so my question for you all is that enough? Is 10% enough to begin to really make a dent in trying to achieve these goals by 2025 and by 2030, with the understanding that we can't do so with biomedicine alone, but we continue to fund the biomedical at a disproportionate rate than we do the psychosocial, as Father Rick puts it. And so, is it enough? And if it's not enough, what will it take?
Well, in order to know what it will take, it helps to know where we are. And that's why, when I think about local faith communities, I don't know what the answer is on how widespread are best practices about HIV outcomes or spreading information or dealing with stigma and discrimination. I just don't know. But my gut sense is that it's going to take a lot of money to do the capacity building within the local faith communities that I think we need to aim for. I don't have a way of saying what the number is. I worked with Lynn Van Rooyen several years ago on a little white paper. This is what it would take to actually train every religious leader in Africa. And we had a hard time coming up with a number, but it was a big one. It was multiple tens of millions annually, maybe more. It was certainly far bigger than anything we could imagine actually doing.
I really believe that when people get the space to do the best they can. I remember in Uganda AIDS Commission helped us when we were struggling with issues. They didn't put money on the table, but they developed what they call a multi-sectoral response that allowed everyone to put on what they could on the table. And the Catholics brought their best strategies of halting new infections. I remember the Anglican bishops went a step further and said, for us, we'll talk about condoms as long as it's in a marriage context. The Islam was saying, oh, we support safe male circumcision because we have an experience. So everyone came on board. And 10% means, if we, for example, put it in the HIV infection and transmission, it would mean by 2025, communities having a tenth of their 2021 infection rate. That would be very significant. So I gain back to say what we need is not really as much as money, although that money will come once we get the right strategy, the right engagement. What we need to do now is to unpack inequality. What does inequality mean in terms of safe behaviors and practices? What does inequality mean in terms of access and adherence to treatment and care and good nutrition? What does it mean to testing and counseling? What does it mean in empowering the most at risk? In fact, I have been engaging with the other stakeholders to say, let's also expand the language of the most at risk or the key populations. That we are talking about two types of key populations. Those who think that they don't need to hear things about AIDS and yet are critical in making sure that stigma and discrimination goes, are also key populations. We need to find a way of engaging them because there are suppliers of stigma and discrimination, and then there are the receivers of the stigma and discrimination. Both of them are key in ensuring that we don't leave them behind. So God has given us the science. That is really not a big issue. Even if we didn't get the cure or vaccine of AIDS, we have enough science now that can really take us to ending AIDS. What is lacking is what has come through this political declaration. And that's why I'm so happy with it, that we are now talking about the social structural drivers and enablers, because it is the risky environments that produce risky behaviors, not the other way around. And once people know that, then they can put what they have on the table. Governments will contribute, intergovernment agencies will contribute. The faith communities will do what they do best, contributing prayer, practical action. But the most important resource we have is love. That love that can be shared to reduce the stigma, the prejudice that kills more than AIDS, actually.
Yeah, Dr. Burley, you'll have to call me Laurel, or I will refer to you as Dr. Burley from now on.
That's fair. That's fair.
No, but thank you. I think this is such a good question, and I just I'm pondering, because I work almost entirely in the field of societal enablers, and it would be far from me to ever say that any amount that's put forward is enough, because we know that no one will commit enough. But I also have just been reflecting that we do still have 12 million people with HIV who don't have treatment, and 47% of kids, right? And a whole bunch of people who do have treatment don't have regular viral load testing, so they don't even know if they're on the right pills. So I think, I don't know if the 90-10 split is the right split, but I know we need a tremendous amount of resources to keep people alive. And that, for me, staying alive has always been number one. And then I can fight everything else because I'm still here. But that said, we did at UNAIDS, colleagues who are really skilled at this kind of work, and I would not be one, did do some really strong modeling, looking at the programs that are needed to reach those 10-10-10 targets, and the best information we have from around the world of what it costs to actually implement those. And because we can see really clearly that, and there's some nice graph in I think it was the report we released in December. I can get it for people if they're interested, but really shows how as stigma goes down, so do other so do infections, so do that we have better health outcomes as stigma goes down, right? As the societal enablers are met, it actually makes a big difference in terms of condom distribution. Condom distribution goes better in enabling environments than it does in non-enabling environments. So it seems like that's so obvious we wouldn't even have to study it, but it does allow us to start to look at what things cost, because if we can invest in societal enablers and start to reduce some of the costs for other things for the biomedical work, then together it makes one package. So certainly I think we need more funding. I assume that the training for all of the African faith leaders that was being costed was so that they could then train the rest of the world. So sort of, I'm guessing that must have been a train the trainer kind of approach. And of course, then that would even cost more. But I'm sure that wasn't factored into that into that calculation. But there's certainly, the more we could invest, I think the faster we could move the needle on protecting people's lives, both by getting them medication and giving them reason to take the medication, and also creating the environment around them that they need.
Yeah, that notion about training all the religious leaders in Africa, it really was just a thought experiment, just to get some sense. Another model that we could look at is what did it cost to scale up? And Rick, I am so impressed with what EDARP does. And the presentation you gave at the side event, to me, was just an amazing example of very solid mixture of faith and science. People so often talk as if they were in conflict, but you is such a beautiful example of those tied together. So what would it take? I mean, right now we know of EDARP, and there are probably others that are similar to yours, but what would it take to sort of scale up and have a whole lot of EDARPs instead of, just you?
Well, yeah, I agree with Laurel. It's those colleagues at UNAIDS that understand this. When I was an undergraduate, I had to get out of accounting because it was lowering my GPA. It just doesn't work in this head at all. So I can't answer that question. What I will say is that if you want to work with the major donors, like PEPFAR, like the Global Fund, or anything about UNAIDS, you have to have data. And so as faith communities invest in an electronic medical record, that's what EDARP did way back when, hired this young, nerdy graduate from Kenyatta University, and he created an electronic medical record in the slums of Nairobi. And so I have data. So what I will tell faith communities, and because we're not good at faith communities, we're just good at being caring and loving and doing nice things. We're not good at measuring it, and you have to measure it. So I can tell you that, okay, yeah, I believe in a biopsychosocial spiritual model of healthcare, and UNAIDS says, so what? And I say, well, because I have 30,000 people, on treatment in the Nairobi slums, and 94% have viral load suppression. So something I'm doing is working, because that's better than my colleagues at Mount Sinai Hospital in Manhattan, New York. So, and let me tell you, we have a lot less money than Mount Sinai and Manhattan. So I've been known to be incredibly cheap. There's cheap interventions. I mention HIV every single homily I ever give since 1985. That's a no-cost intervention. And how has that revolutionized at least the communities that listen to me on Sundays? You know, there's lots of things, you know, and I'm not saying we don't need money. We do. You know, I'm not, please don't say Rick Bauer says we don't need any more money. Yes, we do. But we also have got to be creative, innovative, and how we can bring this into existing structures in the community and in our faith communities that really require no money and have great impact.
I agree with you when you mentioned that we need data, because working, you know, at Rahma, like, you know, starting out, I was pretty much finishing up college, and I was like, oh, I had these ideas. And funders were like, okay, where's your data? I'm like, oh. So then I had to start building up and bringing in data and showing why this is needed. And then funding started to happen. So the answer to the question, I do think we need more money, but I also think we need more than just money. We need a lot more than that. We need support, we need education, we need people, we need data, we need long-term strategies. And we need to train the faith communities. So like you said, you know, part of our people do kindness, all these amazing things, but they don't know how to measure it. So if we're able to show this and show that we're doing this work and that we're having this impact, I think that it really can move a long way. But we have to kind of train, like you mentioned, train the trainers, so they're able to do this and able to have long-term effects, so that we can actually, you know, end HIV and AIDS and really create this pathway to ending stigma and discrimination.
You know, both Khadijah and I have been a part of a significant faith investment over the last year in reaching communities at risk for COVID-19 that has in large part been funded by the National Institute of Infectious Disease, Allergy and Infectious Disease. And it's really given us a great framework for what we could accomplish if we made a similar investment in HIV and AIDS. And so now I'm working with the HIV Vaccine Trials Network to see how we can build out a similar infrastructure for this community engagement that has happened around COVID-19 to be as effective for HIV and AIDS. And that includes, you know, hopefully one day realizing an HIV vaccine, which hasn't come up much here as we talk about biomedicine and intervention, but we're in a time where people have never been more aware of vaccines, of pandemics, of viruses than they have been right now. And I really see it as an opportunity to lift up clinical trials, lift up how the COVID-19 vaccine was developed on the backs of HIV science, and how then we, you know, need to take this energy that we have to kind of move forward to make good on the promise that we've made to the HIV community to end the epidemic by 2030 with either a functional cure or a vaccine to prevent infection. And so I'm wondering, one of the questions I've had to answer is, how then do we get faith communities on board for HIV vaccine, especially when the biomedicine that currently exists works so well when people have access to it, that it's really difficult for many people to volunteer for clinical trials, for example, because what I have available to me is working well now. And so I'm wondering how then do we push the envelope to get faith communities more on board for HIV vaccine research, science, and rollout, given that, you know, the biomedicine for prevention and treatment that currently exists is so good when people have access to it. In many cases, recruitment has become difficult in places in sub-Saharan Africa because of that. And so it's kind of the gift and the curse, if you will, to where the science is fighting the science. And I'm just wondering how you all are working in your own individual local communities to advocate for biomedical intervention in the form of an HIV vaccine. Now that, we're pushing a COVID-19 vaccine all around the world.
You see, we have 3 areas we are working on in the interfaith work here in Uganda. One is to build the sensitivity in the faith sector around risk and vulnerability, but also around the fact that AIDS is vulnerable to competent and compliant people and responses. The second one is to help people aware that in the prevention strategies that we have, there is vaccine and cure advocacy. So in our AIDS anthem, the interfaith anthem, verse number 5 says, let's create peaceful environments free from gender-based violence. Pray, work hard, and build hope for a vaccine and complete cure. Oh, precious is the truth that treats, prevents, and hopes in God. Nothing else that we know, nothing but a comprehensive response to create awareness and sensitivity that, yes, we have tools that work, but we need to continue also praying and working hard and building hope for a vaccine and complete cure, so that people can internalize and say, so if that is the case, I have prayed, what do I now need to do practically? And that is where now intersections with Uganda AIDS Commission, with UNAIDS and PEPFAR programs are bringing religious leaders on the table to say, in terms of treatment advocacy, in terms of vaccine advocacy, this is your role and this is what you can contribute.
Any other thoughts about how we leverage the success of COVID-19 vaccines to further the development and research of HIV vaccines and advocacy for those vaccines in faith communities?
I think that, what we're doing right now with the COVID-19 Prevention Network, we can utilize some of those same methods. But I think with COVID-19 it was more of an urgency with a lot of people, because they're seeing, there are people passing away in large numbers, like right in front of their faces, and we didn't have the vaccines not readily available. But I think if we push it back to the forefront of the importance of kind of getting a vaccine, maybe having more community conversations around it, or going to the people instead of having them come to us, or wait for them to come to us, like bringing up more like Father Barr said, wherever he speaks, he talks about HIV, maybe bring up vaccine there where we go and kind of like talk about it and ask people what their thoughts are around it. Yes, you do have, medication you can take that can sustain, the virus or make it undetectable. But how about being cured from it? Is that something you're so interested in? And kind of get their feedback and their thoughts on it and utilize that data information to put out programming. Like we did a lot of virtual programming, obviously due to COVID, but it worked. It reached people that wouldn't come to our community-based clinic or our organization because they don't live where we live, but doing things online, like virtually, reach people all across the world. So we continue doing things like that. It can be very, very helpful. And if we have people that are CBOs or organizations that are doing this work, HIV and AIDS, talk about this in their educational workshops. Like, talk about what HIV 101 is, talk about You Equals You, talk about vaccines as well. Keep bringing that in so people can know that it's still something that's in our minds that are trying to work towards. And I think, and then in regards to faith leaders, we still are trying to get them to talk about HIV at all. So bringing in vaccines might be a big step to jump to, but it could be on our radar to kind of put it in because, we have so much happening in HIV world. And I think faith leaders, again, they're respected. A lot of them are loved. People turn to them. So if they bring it up and, if they have a safe space in their communities, then people might be willing to learn more about the vaccine process. Like, with the COVID-19 network, we have people that were very apprehensive of the vaccine. They still are. But when they heard about it from their faith leader, they became more relaxed, or they heard about it from scientists or doctors, what's in it and how it's not made from this or that, and how it won't do this and that. It made them feel more relaxed. So I think having professional voices, having faith leaders, having community leaders, having people who have been part of the trials and sharing their experiences can be very, very helpful as you try to roll this out and really get people involved in this.
Ulysses, I'm going to put this right back on you. I'm a very bright guy. I go to the international AIDS conferences and listen to the vaccine talks, and it's like, I feel like, completely, I'm embarrassed how stupid I am. I understand nothing. So if you want me as a faith leader to talk about an HIV vaccine, then you as a doctor need to do HIV vaccine for dummies or HIV vaccine for community clergy, because I don't even know where to begin to educate, to teach about it. I'm just kind of getting my head around mRNA and, and the other kind of COVID vaccines. But when it comes to the HIV vaccine, it's all over my head. And I've been in this for 39 years.
Father Rick, that's actually at the foundation of what we're working on, translating the science so that it's digestible and relatable to the people who need to uptake it for it to be effective. So you'll be hearing from us soon. Dr. Sprague, do you have any final thoughts, or Dr. Barstow, as we draw our very robust conversation to a close?
Yeah,
Laurel?
just I'll say quickly, thank you, yes, thank you, Dr. Burley. UNAIDS is continues to be interested in a vaccine. There are a lot of areas that we're working in, of course, but I think especially the leadership by our executive director around vaccine justice, really around the people's vaccine for COVID, also translates into a commitment to see something similar as possible for HIV. I think what Father Rick just said is so important, that I think also for people, for any social movement, actually, for people living with HIV in any social movement, people tend to get involved when they believe there's some reason for success. I don't know any people with HIV who don't want to be cured. So I don't think it's about not wanting a vaccine, right? But about the cost and benefit of putting yourself out, and especially for so many of us that took experimental stuff when we had no choice. Having a choice is a luxury that we have now, and I think for many of us, putting our potential lives potentially on the line is a tough call, right? Related to the vaccine, taking those kinds of risks with our health is tough. So we need to know that there's a good reason. That the science, we need to understand the science as well, that it really will make a difference in moving the science forward. But then just for closing thoughts, I just want to just say a sincere thank you to you and to Mike Schunemeyer, who have organized this session. It was just remarkable to be here and to listen to the dialogue and the thoughts put forward by the different leaders. You're exactly right. There are a whole bunch of people here who've been giving this these kinds of issues a lot of thought over time, and it's lovely to have the opportunity, even from so far away, to actually hear your good questions, hear the responses, and really take the conversation to a new level, almost as if we were able to be in a room together. And that's a real pleasure at this point in time. So I thank you and all the panelists. I've learned a lot and really enjoy being in this space with you. So thank you.
Dr. Barstow, any final thoughts?
Yeah, well, first of all, I really appreciate Mike and Ulysses for organizing this. And for the incredible contributions from everybody else. This has been really a real pleasure to be a part of this. If there's a final thought, it's that I've sometimes given talks where I ask the question, has religion helped or hurt the global AIDS response? And the answer is almost always yes and yes. And that's, as we've all noted, there are times when we've done things, when people of faith have done things that have hurt, and times when we've done things that have harmed. And so to me, if there's one goal for the next 5 years, it's let's do a whole lot more of the things that help and a whole lot less of the things that hurt. And I think if we can take that as the guideline, we'll be moving in the right direction.
I think that is an excellent note to end on. I want to thank each and every one of you. I extend my sincerest gratitude for your partnership, for your commitment to end HIV as a public health crisis by 2030. But I also want to thank you for your friendship. We have all been in the room together. We have spent many hours together laboring on these very important issues. And in doing so, we have, I would say, developed a very strong personal relationship. And so this really is a family affair when we come together to have these conversations, despite our distance, despite our faith backgrounds, despite our HIV and AIDS status. And so I'm grateful for you all and for the relationship that we have and the work that we continue to do together. I'm thankful for the audience and those who have joined into this conversation, both via Zoom and on our social media platforms. And I look forward to the continued engagement of this talk as it continues to live on the internet where people can engage and otherwise. I do want to draw the audience's attention to upcoming events that you can be engaged in that will be hosted in partnership with the United States HIV and AIDS Faith Coalition, along with others. I want to also let you know that there is an opportunity to make a donation to our coalition. We operate solely on the philanthropy and the grace and the gifts of the general public to be able to do this work. And so we give thanks for your support in any way that you can. And tune in to another conversation next month on Wednesday, July 14th, that will talk more about how the HIV vaccine research helped to inform COVID-19 research and how we can possibly come to have a viable vaccine for HIV that will help us achieve our 2030 goals. And so with that, I want to bid you all a wonderful day and the rest of your week. And again, thank you for your participation in today's conversation about making our commitments real to end the HIV epidemic by 2030 with a faith-forward lens following the United Nations high-level meeting on HIV and AIDS. I thank you and God bless.